All right, good morning. This morning, I have the privilege of introducing Dr. Esther Chung as our Grand Round speaker. She is our current third-year REI Fellow who will be graduating at the end of this year. Originally from Los Angeles, she attended Harvard College, where she concentrated and received highest honors in neurobiology. Following this, she obtained her medical degree at Harvard Medical School in 2018. Then she did an OBGYN residency at Duke, and we were extremely fortunate in being able to recruit her to Stanford Fertility as an REI fellow. Dr. Chung has a strong interest in improving access to care and fertility preservation. She, during her fellowship, has developed the cost-effectiveness Cardinal Protocol, which is an egg freezing protocol to reduce the financial burden and time commitment required to pursue oocyte cryopreservation. This protocol has now been implemented as an institutional protocol at Stanford, and thanks to her research efforts. She also works closely with fertility tech startups to address inefficiencies in fertility care and to improve patient advocacy and education. After graduation, Dr. Chung plans to join HRC Fertility, a private practice in San Francisco that is academically affiliated with USC. On a personal note, I think Dr. Chung's enthusiasm, curiosity, determined work ethic, and her commitment to innovation have been a real joy to watch during her fellowship training. She has really hit the ground running and done a wonderful job as a fellow. Today, she will be diving into current data and the debate on whether to treat infertile patients with subclinical hypothyroidism. Take it away, Dr. Chung.
Thank you so much, Dr. Alvaro, for the kind introduction. And so I'm really happy to be here today and to talk about this topic. So just to start, it's fairly often in our clinical practice as REIs and as OBGYNs that we identify subclinical hypothyroidism in our infertility and pregnancy loss patients. In light of a pretty controversial recent guideline put out by ASRM, this felt like an important topic to review to try to answer the question for ourselves: to treat or not to treat? Are we really saying RIP to TSH? Shout out to a couple people, Dr. Humphreys, who shared some of her slides with me, as well as Dr. Docio, our resident thyroid expert in the endocrine department, for her input on my presentation. I have no relevant disclosures. As always, to start with a clinical scenario, this REI patient initially presented to us as a 39-year-old with DOR who wanted to try to conceive as a single parent. She had previously frozen eggs, but wanted to do donor sperm IUI first. And prior to this, she had no history of thyroid issues, asymptomatic. And given her intentions to conceive, her REI ordered a TSH, as was our clinic standard at the time, that came back at 5.24. She was then started on Synthroid, which brought it down to 2.37. She became pregnant after a donor sperm IUI in May of 2022 with a positive beta, and we checked a thyroid TSH at the time, and it was 7.96. So the patient reports forgetting to take her Synthroid, and so she was restarted on the medication. A repeat in 1 month showed that it was still elevated at a TSH of 5.2, so her REI increased her dose. She unfortunately had a miscarriage of this pregnancy with products of conception testing showing euploid. And in September, when her beta HCG dropped to less than 5, her TSH was checked again and was noted to be very, very low at 0.018, and her Synthroid dose was decreased. A month later, her TSH rebounded all the way back up to 11, likely in the setting of a postpartum thyroiditis or hypothyroidism developing after her miscarriage, and a consult to endocrine was placed, along with an increase in her dosing. A month later, given a persistently elevated TSH at 9, her next donor IUI cycle was delayed. The endocrine team had ordered TPO antibodies, which returned positive at greater than 900, and they diagnosed her with Hashimoto's and increased her dosing. She continued on this dose, and in May 2023, she conceived again, this time spontaneously or on her own. Her Synthroid was automatically increased to 100 by endocrine, given that she was pregnant and per their guidelines. And TSH at that time was found to be borderline for them at 2.58. Unfortunately, she miscarried again. This was her second loss now, although later explained by abnormal chromosomes. Then around January, she was near the end of her first FET attempt, but this was canceled, unfortunately, given a dropping estradiol level, and also because her TSH was noted to be elevated at 4.14, and her thyroid medication was increased again. Then 1 to 2 months later, she had her second FET attempt with an actual transfer occurring in early March. A TSH was checked at the time of the transfer and was 3.64, so her dose was increased again. She had a positive beta a couple weeks later, and endo increased her dose again automatically. And then a follow-up TSH was 2.35, so just below 2.5. But given she was pregnant, they still increased her dose. After which endocrine continued to frequently check her TSH, a bit more frequently than the monthly intervals, all the way from March through June. And as of now, actually in November, last I checked, she was 38 weeks pregnant, still on 112 micrograms of Synthroid, and she should be, I think, delivering soon. So the point here is like lots of TSHs drawn almost 30 times in pre and early pregnancy for this patient, many dose adjustments, and 2 treatment delays later, she got her desired outcome. I think what's really interesting here is she started off as a patient actually without infertility, but over her treatment course, she ended up having 2 miscarriages, developed hypothyroidism, and thyroid autoimmunity. So I think this is just a good backdrop to start, and then we'll kind of go into the basics here. So to review the basics on the link between thyroid function and the HPO axis, if there is primary hypofunction of the thyroid gland, there will be increased secretion of TRH and increased pituitary sensitivity to TRH. This increases TSH production and prolactin secretion, potentially leading to hyperprolactinemia. And elevated prolactin, as we know, can inhibit GnRH, disrupting the HPO axis. But even in the absence of elevated prolactin levels, hypothyroidism is known to cause irregular menstrual cycles through other effects on ovarian function at the level of folliculogenesis, disruption of pulsatile FSH-LH secretion, lowering sex hormone binding globulin levels, other metabolic changes to the body, and impacts potentially on the endometrial lining. And going into definitions a little bit, as opposed to overt hypothyroidism where you're symptomatic with an elevated TSH and an actually low free T4 or with a TSH greater than 10, in subclinical hypothyroidism, you find elevated TSH levels greater than what people say the upper limit of normal, with normal free T4 levels, and generally asymptomatic patients, and they make up about 4 to 8% of the reproductive age population. Thyroid autoimmunity has also been a topic of interest, with the prevalence of TAI estimated to be as high as 10 to 27% in patients with infertility, and possibly even higher in RPL. Anti-TPO antibodies have been causally implicated in Hashimoto's thyroiditis, where these antibodies attack thyroid tissue, causing progressive fibrosis. For those of you who don't remember, TPO is an enzyme on the cell membrane of thyroid cells responsible for catalyzing the conversion of thyroglobulin into T3 and free T4. And the other autoantibody that our endocrine colleagues care about is anti-thyroglobulin. And as you can see on the left, the prevalence of these antibodies, both of them, increases at higher TSH levels. And the reason we talk about TPO antibody positivity is that it has been thought to confer risk for progressing from a euthyroid to a hypothyroid state during pregnancy. And thus the American Thyroid Association had recommended that TSH be measured and followed even in euthyroid TPO antibody positive patients until mid-pregnancy. So recommendations for thyroid screening in women with infertility have varied significantly over the years and across different society guidelines. And you can kind of see the evolution and the differing opinions here, most notably ACOG in 2015, not recommending universal screening and testing, only for those with thyroid disease history or presence of symptoms, and only recommending treatment for overt hypothyroidism. But ACOG didn't really have specific recommendations for patients with infertility. In the same year, ASRM, on the other hand, recommended TSH screening in patients with evidence of ovulatory dysfunction, so irregular cycles, or otherwise at high risk. And what that meant included a history of infertility or a history of loss. And they also said that TPO antibody testing could be considered for a TSH over 2.5. And in terms of treatment, ASRM felt that there was good evidence to treat TSH greater than 4 to maintain levels less than 2.5, and to even consider treatment in TSH between 2.5 and 4, although this was based on weaker evidence. They also said consider treatment for positive TPO antibodies when TSH was greater than 2.5. And then the American Thyroid Association in 2017 was more in line with ASRM in 2015, saying all infertility patients should get TSH testing and that we should treat subclinical hypothyroidism based on a TSH greater than 4, given minimal risk of taking Synthroid, and to consider treatment even for euthyroid TPO positive patients, specifically in the ART population. So a lot of confusing language going back and forth. And it still continues several years later. ACOG in 2020 updated their guidelines, adding in stronger language against screening for thyroid disease, mainly because there was newer data that demonstrated no improvement in neurocognitive outcomes in children born to women with SCH or subclinical hypothyroidism during pregnancy. And then ASRM this year published what I referred to as their controversial RIP TSH statement that drastically changed their language to say universal screening is not recommended in those attempting pregnancy, including in infertility patients undergoing ART, but did maintain that we could check this still in patients with irregular cycles. They also more strongly stated not to screen for thyroid autoimmunity in infertility patients, but could be considered in RPL. They recommended not to treat subclinical hypothyroidism in women trying to conceive and not to treat during pregnancy. I will say that the American Thyroid Association is still working on updating their guidelines, which I think will come out soon, but I do believe they will be different from what ASRM had to say. I'll go through these individually in the presentation, but really the takeaway is RIP TSH, don't screen and don't treat, was like the main point of this new guideline. So the guideline starts off by stating the limitations of the literature, as they should. They reconsidered previously included studies, reviewing them critically in this guideline. And they highlight that many RCTs actually have critical flaws, and a notable percentage in general contain falsified data. And this is how they justify that they ended up with completely different conclusions compared to 2015. So the definition, according to ASRM, of subclinical hypothyroidism is when TSH exceeds the upper limit of normal for the lab with a normal free T4. And reference ranges should be based on age, as TSH ranges change with age. And if an age-based upper limit of normal for a third-generation TSH assay is not available in an iodine-sufficient area, such as where we practice, an upper limit of normal of 4.12 should be used. And I wanted to pull up, the most common, what we see in our patients, which is our Stanford REI lab, and I also pulled up a LabCorp reference range, and these both do not appear to be age-based reference ranges. So I argue here that we should use 4.12 as our cutoff, given that we don't have age-based ranges in our labs. So then I think the question of where did this TSH cutoff of 2.5 come from? And the 2.5 cutoff is referenced actually from a report back in 2003 by the National Association of Clinical Biochemistry. They concluded from their studies that more than 95% of rigorously screened normal volunteers have serum TSH values between 0.4 and 2.5. And they believe that this data suggested that for the 5% of people with TSH above 2.5, this may indicate some underlying thyroid dysfunction, hence the recommendation for that to be an upper limit of the reference range. Other things that support this, several studies had shown that patients with TSH levels above 2, especially those with positive anti-TPO antibodies, had a higher likelihood of developing or progressing to overt hypothyroidism. And this led to some providers to advocate for earlier treatment in this population to stabilize thyroid function and potentially prevent further progression. The language in ASRM's 2015 guidelines about using 2.5, and they refer to this as the first trimester pregnancy threshold. In women trying to conceive, they said, this is controversial. But in the updated 2024 guidelines, the language is stronger about how lowering this threshold was not felt to be supported by evidence, that we should use defined age-based cutoffs for non-pregnant patients trying to conceive. And it's important to know where this number came from, the origin story. So the Wickham survey, not sure, I never heard of this until I was looking into this topic, but the Wickham survey was a seminal work that formed the basis for a concern about lower TSH levels. The study followed 3,000 adults in the UK for about 20 years and found that a TSH greater than 6 and being thyroid antibody positive increased the odds of developing overt hypothyroidism by almost 40 times. They identified that both older age and higher TSH levels at baseline were associated with higher risk. They created a model to predict the probability of progression from subclinical hypothyroidism to overt hypothyroidism over time. And you can see there is an inflection point at a TSH of 2, beyond which the risk of overt hypothyroidism goes up. And for a given TSH level, the odds of developing hypothyroidism are higher for antibody-positive patients compared to antibody-negative individuals. So the National Association of Clinical Biochemistry Guidelines back in 2003 took this work from Wickham survey and said that, having that TSH of 2.5 was possibly indicative of early stages of thyroid failure. Some severe, a severe presentation. But only 8 years later, so not really, almost a decade later, there was a letter published in Clinical Endocrinology criticizing the Wickham survey, given that the model would not accurately represent the risk for women at different ages, because that model that I just showed you was actually built for women in their 50s. And the whole point of this letter was to say, the effect of age on hypothyroidism risk is not linear, and so younger and older younger women have a very different risk profile, making this not a generalizable model. But all the guidelines have kind of been based on that. So take-home points thus far is that we should, at Stanford, use 4.12 as the upper limit of normal, and that a TSH between 2.5 and 4.12 should be considered normal or euthyroid. But in interpreting, let's say, a TSH greater than 2.5, and or a patient with thyroid autoimmunity, so positive antibodies, they may be more likely to develop higher TSH levels in the future or overt hypothyroidism, but possibly decades into the future, especially if they were older at age of initial test or they have a family history of thyroid disease. So as mentioned before, ASRM now recommends not screening for patients attempting pregnancy and patients with infertility undergoing ART. They said we can consider risk-based screening, including patients with irregular cycles, but they label it aggressive case finding, which I thought was an interesting choice of words. Subclinical hypothyroidism is by definition a laboratory diagnosis with what feels like arbitrary cutoffs. So why did we hypothesize as providers that subclinical hypothyroidism would have clinical significance? It's because overt hypothyroidism does, as our MFM colleagues know, and early studies did not the best job of separating the two. And so could treating subclinical hypothyroidism at lower cutoffs improve fertility and pregnancy outcomes and prevent progression to overt? On the other hand, lowering the cutoff would result in nearly 20% of the US population being diagnosed with subclinical and nearly 30% of those undergoing IVF. So a kind of an impractical diagnosis. Okay, so now moving on to the outcomes that they actually looked at. The ASRM guideline addresses the impact of subclinical on these 4 clinical outcomes: miscarriage, infertility, adverse OB outcomes, and neurodevelopmental outcomes in children. First, we'll talk about miscarriage. So the bulletin starts off examining 3 meta-analyses on this topic, and with this first one by Maraca et al. In 2016. ASRM stated that it was difficult to draw conclusions from this, given it included multiple studies, almost half of which that did not meet the actual definition of subclinical. And unfortunately, the study did not perform a sensitivity analysis of the studies that actually met the definition. And majority of studies also screened women in pregnancy, so all the way up to 20 weeks gestation, with almost no studies looking at preconception subclinical hypothyroidism. But if you actually double click into the meta-analysis, I was curious to know what the actual results were. That included about 3,500 women with subclinical hypothyroidism. It was found that subclinical hypothyroidism was associated with a higher risk for pregnancy loss, placental abruption, and neonatal death compared with euthyroid pregnant women. Pooled estimates showed a 2 times increased risk of pregnancy loss in patients with untreated subclinical, and you can see a similar effect in women screened for subclinical hypothyroidism between 0 and 12 weeks gestation, but this risk seems attenuated in studies that included women screened all the way up to 20 weeks gestation. 2 additional meta-analyses included in the guideline demonstrated no increased risk of miscarriage or similar risk of loss. So this is kind of what we had from the meta-analyses. And then when we go to prospective studies, they mention, the first that was mentioned was Plowden et al. In 2016 in about 1,200 unassisted conceptions, where pre-pregnancy levels, TSH levels greater than 2.5, did not show an increased risk of first trimester loss. ASRM also mentioned a prospective study by Liu et al. In 2014 that screened 3,315 women at 4 to 8 weeks, so decently early, which actually did demonstrate an increased risk of first trimester loss in subclinical hyperthyroid patients with a TSH greater than 5.2, with an odds risk of 3.4 that was significant. So this was actually, at this point, like the largest prospective study that was included in the guideline that actually did say there were increased odds of miscarriage with untreated subclinical. Double-clicking into Liu et al. Study, as I mentioned, there was a statistically significant higher risk or higher odds of miscarriage in those with a TSH greater than 5.2. But when the TSH is between 2.5 and 5.2, there was no statistically significant increased odds of miscarriage. But they did see that isolated thyroid autoimmunity plus having a TSH greater than 2.5 with thyroid autoimmunity was associated with an increased odds of miscarriage. So this was, as I said, the largest prospective study included in the guideline. It actually argued for, I guess, the fact that there is an association. There were additional retrospective studies of varying cohort sizes as well, and several retrospective studies that they dug into were in IUI and IVF patients, and they all a lot of them demonstrated no difference in miscarriage rates. A larger intermediate study by Chen et al. Looking at 7,000 patients did demonstrate a slightly increased risk of loss. And so based on these studies presented, ASRM makes the statement that subclinical hyperthyroidism during pregnancy, as well as those with a TSH between 2.5 and 4, is not associated with miscarriage based on a moderate level of evidence. And they recommend that we counsel women that subclinical hypothyroidism, as well as a TSH between 2.5 and 4, are not associated with an increased risk of miscarriage. So moving on to a study not included in this guideline. This is actually the largest prospective cohort analysis of its kind, which was published in 2022. So before the guideline came out, but it was not included. Yang et al. Published at JAMA. This was a nationwide population-based cohort study of 11 million participants in China, followed from 2013 to 2017. The study suggests that they looked at preconception TSH levels, which is a strength, outside reference range within 1 year before pregnancy, and they found that that was associated with an increased risk of miscarriage. And you can see that a TSH greater than 4.88 does have significantly higher odds of miscarriage than with a TSH less than 2.5. And even with the 2.5 to 4.8 group, you do see an increased, statistically significant increased risk of miscarriage. And there were a few commentaries in response to this study. This one was by Dr. Alexander, an endocrinologist at the Brigham. He had a great review of this. He applauded that maternal TSHs were obtained before, not just during pregnancy, demonstrating adverse risks with conception, that it was the largest cohort analysis of its kind, as I mentioned, and found that higher TSH was associated with a decreased ability to achieve pregnancy, as well as an increased risk of pregnancy loss, as you just saw. He felt that this was a geographically diverse cohort, and felt that that having a narrow TSH window in the lower half of the reference range may be optimal for future pregnancy. But he does go on to say that a common follow-up question from this paper would be whether treatment is reasonable for infertility patients with TSH within reference range, especially when TSH values remain in the upper 2.5 to 4. And he says that this new data does not suggest a change to current practice being not to treat patients between 2.5 and 4. So the answer still remains no at this time. But as I mentioned, the endocrinologists do treat patients with subclinical hypothyroidism, TSH greater than 4. So that wouldn't be a change from their practice. So I put up a lot of the studies that were included in the study and not included in the study, and just weighing the evidence, I can't say with confidence, and I can't counsel my patients with confidence that subclinical hypothyroidism is not associated with miscarriage, which is what ASRM took that stance. So I would say possibly here. Moving on to infertility. There's really very limited good quality data on this topic, with only 5 retrospective low to intermediate quality studies. There seems to be a low prevalence of subclinical hypothyroidism in infertile women in some studies, but higher in other studies. And there was one study that I'd like to draw attention to deemed a low quality study, but it did include 11,000 Danish women. And the ASRM guideline reported no association of subclinical hypothyroidism with infertility, with a p-value of 0.09. But when I looked up the study myself, conclusions of the authors were actually the opposite. So I'll show you guys. As I mentioned, this was a cross-sectional study of 11,000 females in the Danish population. They defined subclinical hypothyroidism as TSH greater than 3.7. But this 0.09 comes from this table, which describes the characteristics of the women in the study and states prevalence. And prevalence provides descriptive information about how common an outcome is in the population, but it doesn't test, the p-value for this doesn't test the exposure outcome relationship. For that, you need to calculate an odds ratio, and that will give you the measure of association between an exposure and an outcome. So the p-value with the odds ratio is actually what will tell you whether the observed association is statistically significant. And untreated, and this is from the study itself, untreated subclinical hypothyroidism was found significantly associated with childlessness compared to euthyroid controls, with an odds ratio of 0.7, with a p-value of 0.004, and with lack of conception with an odds ratio of 0.75. So I think this was a misinterpretation of p-values, using it from table 1 instead of table 3. And again, just to always, when you're reading guidelines, always to take everything, with a grain of salt, go back to the original literature to see what was actually being said. So ASRM reports that based on these limited studies, there is weak evidence, which is true, that subclinical hypothyroidism is not associated with an increased risk of fertility, but they soften their language and say there's insufficient evidence to counsel women as such. And the American Thyroid Association also said the similar thing: insufficient data exists for recommending that for or against routine therapy in subclinical hypothyroidism in infertile women. So this is another population-based, or the same population-based cohort study that I presented for miscarriage that was also not included. And again, to refresh you guys, it's the study that looked at 11 million participants in China. And it actually suggests that preconception TSH outside reference range within a year before pregnancy also was associated with an increased risk of prolonged time to pregnancy. So they looked at hazard ratios of fecundability here, and groups with the highest TSH levels had lower odds of conception within 1 year of follow-up. Of note, patients with a slightly lower preconception TSH between 0.1 and 0.36 actually had the highest odds of pregnancy in this group. So I think more evidence to suggest that there might be an association with fecundability, fecundity, infertility. So I also believe that there may be insufficient evidence to counsel women that SCH is associated with infertility, but there could be a possible association just based off of some of the more recent, larger data that I cite here. Moving on to adverse OB outcomes. Again, similar issues here with limited low quality studies, rare clinical outcomes, significant heterogeneity, and defining subclinical, and when TSH was measured. So ASRM felt that a lot of the meta-analyses were not informative for this guideline because of this. There was one moderate quality RCT by Narzarpour et al. In 2018 that unfortunately defined TSH as greater than 2.5 instead of 4 with a median of 3. So technically including euthyroid patients. They found no effect of treatment on their primary outcome of preterm delivery in comparing subclinical hyperthyroidism patients treated with Synthroid or left untreated. They did a secondary analysis modifying the cutoff to TSH greater than 4, and there was a significant reduction in preterm delivery with a relative risk of 0.38. ASRM pointed out that this was not included in the A priority stat plan and thus considered post hoc, and criticized that by doing so, it ignores randomization by moving large numbers of patients out of their assigned group, which is true. So they actually deem this lower quality evidence. Other intermediate quality reviews demonstrated higher odds in subclinical hypothyroidism to have adverse OB outcomes. And they vary from placental abruption, PPROM, neonatal death, to preterm birth, preeclampsia. So very varied, I would say. There was one retrospective study that was the only one to evaluate preconception TSH in 50,000 women in China, and by Li et al. And it demonstrated that subclinical hypothyroidism, a TSH greater than 4.2, was not associated with preterm delivery, pregnancy loss, and large for gestational age births, but did find that in another follow-up study on 1,500 patients where they checked TSH in the first trimester as opposed to preconception, there did seem to be an association with hypertensive disorders of pregnancy, preterm delivery, and previa. It's unclear why the same center produced studies that had disparate outcomes. But I will say this, it's not mentioned in the practice bulletin or the guideline, but their composite score that was combining a lot of these outcomes actually was statistically significant. So this was the actual study, and the composite adverse pregnancy outcome based on pregnancy loss, small for gestational age, large for gestational age, and preterm delivery was higher in subclinical hypothyroidism patients by 13%. But if you look at pregnancy loss alone, it was not statistically significant. But in the study themselves, they did what they say is a non-ad hoc. So they had planned this sensitivity analysis ahead of time where they excluded patients who were previously treated for an abnormal TSH and women with chronic acute illnesses that could actually impact thyroid function. And by eliminating these confounders, they actually found statistically significant higher odds of 22% in the composite group, as well as 23% higher odds for specifically pregnancy loss in subclinical hypothyroidism. And the slightly increased risk for small for gestational age was no longer significant in this group. Another intermediate quality study of over 1,000 pregnancies with TSH demonstrated a small absolute increased risk of fetal distress, preterm delivery, fetal loss, poor vision, and neurodevelopmental delay. But overall, it is difficult to draw conclusions from the study given the small numbers of cases. So per ASRM felt that this indicates a very small absolute risk. Then there was a larger intermediate quality retrospective study out of Parkland by Casey et al. In 2005 that screened TSH up to 20 weeks, so including the first and second trimesters, but average gestational age at enrollment was around 12 weeks. So a little bit late again. They defined subclinical hypothyroidism as an elevated TSH above the 97.5 percentile, which actually ranges from 2.74 to 5.09 in pregnancy. And they found associations of subclinical hypothyroidism with a 3-fold increased risk of placental abruption and a 2 times increased risk in preterm delivery. Their conclusion was that the previously reported reduction in IQ of offspring of women with subclinical hypothyroidism actually may be related to effects of prematurity, given they found that the increased risk of preterm delivery in this population. But they do close their paper saying that there's not a really understood mechanism disease whereby lacking thyroid hormone somehow leads to preterm labor or abruption. The hypothesis they proposed was that thyroid hormone is necessary for normal placental development. The authors did say they were of the view that until randomized control trials were done to demonstrate that thyroxine supplementation could obviate any of these maternal fetal comorbidities, widespread screening and treatment of subclinical hypothyroidism during pregnancy would be unjustified. Then a larger prospective study now of 8,000 participants in 2014 demonstrated some conflicting results, with subclinical hypothyroidism in the 3rd trimester being associated with increased risk of gestational hypertension, IUGR, low birth weight, and PROM, but no significant associations apparently in patients diagnosed earlier in the 1st and 2nd trimester. So a little bit of a confusing study here. So overall, all of these studies were, again, low to intermediate quality. And when they actually did find adverse OB outcomes, the findings are kind of inconsistent across studies and across a variety of different adverse OB outcomes. And so we do lack significant data on the association between specifically preconception subclinical hypothyroidism and poor reproductive outcomes. But there may be some association between subclinical hypothyroidism diagnosed during pregnancy on adverse outcomes. And so based on all of this, ASRM stated that subclinical hypothyroidism is not associated with adverse OB outcomes, but they do not deny that some studies did show increased risk, particularly with testing later in pregnancy, and that but they still hold to the fact that we should counsel women that subclinical hypothyroidism is not associated with increased OB risk. I actually think just putting all the studies together, this is an inconclusive. We don't have enough data to say that untreated subclinical hypothyroidism isn't associated with adverse OB events. It's just we don't have enough data. We also really lack preconception data. So now touching briefly on neurodevelopmental outcomes in children, recent RCTs on subclinical hypothyroidism haven't demonstrated a positive association between subclinical and reduced intellectual development, and we'll touch on these briefly here. So this is the CAT study by Lazarus et al. Published in New England Journal of Medicine of almost 22,000 women randomized at a median of 12 weeks 3 days to a group screened for thyroid dysfunction or to a control group who got their serum drawn but analyzed at the end of pregnancy. So they were the untreated group. Treatment with 150 micrograms of Synthroid was started at a median of 13 weeks and 3 days in the screened women. And they found that there was no difference between groups in the IQ of children at 3 years of age. So again, this is kind of a little bit late, as I will say. And then they did a follow-up study of CATS, and they called it CATS-2, and it showed that their therapy did not improve child cognition at 9 years old, where they repeated the IQ testing at that point. And then another multi-center RCT by Casey et al. Found similarly negative findings at 5 years old. But here again, mean initiation of Synthroid was even later at 17 weeks. So that is important to note here. So the study limitations, as I mentioned, as I was showing you the studies, is that there was really late initiation of LT4 therapy and possibly too late in gestation to have a major influence on brain development. Other, things that people have criticized is that there were relatively high fixed dosing that could have negatively impacted IQ, and the questionable accuracy of IQ testing in young children, and the inadequate power to detect subtle differences in cognition. So based on this, ASRM states they strongly recommend that we should counsel that subclinical hypothyroidism is not associated with adverse neurodevelopmental outcomes in offspring. And moving on to this scale again, I would say that based on this, evidence weighs toward no, that not treating subclinical hypothyroidism diagnosed in pregnancy isn't necessarily associated with worse neural outcomes, but I want to emphasize that, again, this is subclinical hypothyroidism diagnosed in pregnancy as opposed to pre-pregnancy or very early pregnancy. So these are the different take-home points from ASRM on the left, and on my take-home points on the right. I really do think that subclinical hypothyroidism may be associated with miscarriage and may be associated with impaired fecundity or infertility. It seems like we lack sufficient data about preconception subclinical hypothyroidism and adverse OB outcomes, and that some studies have shown an increased risk with subclinical hypothyroidism identified later in pregnancy. Untreated subclinical hypothyroidism in pregnancy does not seem to be associated with adverse fetal neurodevelopmental outcomes, but again, data is limited on associations with preconception TSH. Okay, so moving on to the main, point, to treat or not to treat, so what kind of thing. Many society guidelines have discussed that the evidence is weak or lacking to demonstrate the benefit of treatment for subclinical hypothyroidism in women desiring pregnancy or pregnant. But they also mention that LT4 is inexpensive and unlikely to cause harm. ASRM specifically aimed to look for evidence that the intervention was clearly beneficial before recommending it. And they felt that an intervention being inexpensive and unlikely to cause harm was not justification for screening and treatment because there was insufficient evidence of benefit in the literature. So we should look at the literature. So in 2005, there was a high quality randomized trial by Negro et al., but unfortunately, it only looked at euthyroid women with infertility and thyroid autoimmunity with TPO antibody positive. So completely irrelevant to the population we want to know about, which is subclinical hypothyroidism, but it is included in the study. Kim et al. Published in FNS in 2011, and it was an intermediate quality randomized controlled trial. Intermediate because it was non-blinded, small numbers of patients, but they looked at subclinical hypothyroidism defined as a TSH greater than 4.5 and live birth rates in the IVF population. And live birth rates were significantly higher, 53 versus 25%, and miscarriage rates were higher in the control, 33% versus 0%. But as we'll get to a little bit later, the numbers were really small, so we're at high risk of type 1 error. The practice guideline also then includes the CATS trial again, even though the CATS trial itself didn't directly report pregnancy outcomes because it was about neurodevelopment and IQ, but they did report the number of people who reported back for testing of their child as an indirect measure of whether they got pregnant or whether they had a successful live birth. But this to me feels like an extrapolation and not really what the study was testing for. So this was the Kim et al. Study, and 0% miscarried in the treatment group. And, you might take away from this, or so the criticizers of this study said, Synthroid is basically curing miscarriage and enabling 0 patients to miscarry. And if you were to presume that was true, then somehow miraculously Synthroid cures aneuploidy, which is our most common cause of miscarriage or not getting pregnant. And I think it's just interesting here. I put in a couple one scenario here where we increase miscarriage rates by 1 in the treated group, and the p-value becomes completely insignificant. And so this is my point when I say, type 1 error here. Like, yes, this was a statistically significant result and it feels dramatic, but the numbers were small, and because of it, just adding 1 miscarriage will change the statistical significance of this finding. So just something to be mindful of, but this was actually the right population of patients we wanted to look at, and it was still a randomized controlled trial. So then there was this low quality RCT that the guidelines spend a lot of time discussing to highlight data integrity concerns and to justify their decision to exclude this. from the evidence, because previously they included it in the evidence, and they felt that this was very important because the study was previously included in a lot of systematic reviews and meta-analyses, except for a Cochrane review. This study was by Abdul Rahman. The results don't really make much sense. Miscarriage was initially reported as a percentage, 9 and 13, with a p-value of 0.03. And it's actually really hard to find a 4% statistically significant difference with only 35 patients in each arm. So if you calculate, like if you go into a power calculator online and just put in what you're looking for, to detect a 4% difference as statistically significant, a sample size estimate shows that you would need about 900 to 1,000 patients per arm. And so because readers found this very odd, they reached out to the editors of the journal. And then the editor-in-chief tried to reach out to the primary authors, but they didn't respond. So then he took the liberty to go ahead and say these are actually raw absolute numbers and not percentages. But when he does that, upon recalculating the p-values, they change dramatically from a p-value of 0.03 to 0.44, p-value from 0.02 to less than 0.0001. Also, everyone treated with Synthroid is getting pregnant, 35 out of 35 patients, with 100% pregnancy rate versus 10 in 35 in the placebo group. And so again, the comment that, is Synthroid actually curing aneuploidy, which is an implausible theory, if we accept the assumption that these are raw numbers instead of percentages. But also the numbers don't add up. If 35 get pregnant, 9 miscarry, and 26 deliver in the treated group, but in the placebo group, 10 would get pregnant, but 13 somehow miscarry. So we have 3 women that miscarry who don't get pregnant. So really not a good study. And it's true, a lot of practice, the practice document mentions that every single, previous practice document that said to treat every single meta-analysis included this Abdel Rahman RCT. And the effect size on live birth with treatment is like 9 compared to like 1 to 2 in other studies. And Rouse et al. Meta-analysis in 2018 actually did do a sub-analysis where they took it out. And you could see it in the text here. When they took out the study by Rahman et al., the findings were no longer statistically significant, and the heterogeneity went down in the meta-analysis from 15% to 10% when this study was removed. But this is just demonstrating the point that, one study can really impact the findings of a meta-analysis. So that point I agree with. So there was a randomized controlled trial or a clinical trial that actually and this is something that you guys should know about, called the Postal trial, whether LT4 treatment affects pregnancy outcomes among women undergoing IVF embryo transfer who had normal thyroid function and tested positive for TPO antibodies. And eligibility criteria were 23 to 40, BMI 35 or less, and a TSH, again, between 0.5 and 4.78, so inclusive of the euthyroid population. And there were 300 patients in each group. And they found that treatment did not reduce miscarriage rates or improve live birth rates in this population compared with no treatment. But again, and based off of all of this data, ASRM's like, okay, treatment of subclinical hypothyroidism does not improve pregnancy loss, clinical pregnancy, or live birth, and that treatment is not recommended to women desiring pregnancy or trying to conceive, and that we should not screen as well. This was another study called the Tablet trial, also a famous trial, published in the New England Journal of Medicine. And in this study also, they found that levothyroxine treatment did not reduce miscarriage rate or improve the live birth rate compared with usual care. But the problems with both the Postal and Tablet trial was that they studied a population of women that was very varied. So they included both infertility and miscarriage patients. This was mainly a euthyroid group, meaning their TSH was not actually greater than 4. And in fact, median TSH was well below 2.5 at enrollment and stayed less than that in all trimesters in the studies that checked serially. And also the thyroid antibody titers that were assessed used very different assays and considered all borderline or indeterminate values as positive. So I know that a lot of our endocrine colleagues do have concerns about these two trials, but I think the main point with these trials is that it's not relevant to the subclinical hypothyroidism patient population would be what I would argue. This was a follow-up analysis of the tablet trial by Sophia Gill, and they did actually find that about 7% of patients in that trial developed subclinical hypothyroidism or overt hypothyroidism within 1 year, preconception or in pregnancy, and most of the cases actually emerged pre-pregnancy. Of note, 2% of patients developed thyrotoxicosis, and most were in the synthroid group. So again, getting to the point that ASR made that, not even if it's low risk, interventions can have some negative side effects. But basically, I think it's just a good follow-up study that shows that people will develop subclinical in this population with TPO antibody positive patients. So based on the review of this literature, it seems the answer is clear to not treat euthyroid patients with TPO antibody positive. But again, that was never the specific population we had in mind, which is the subclinical hypothyroidism group. So I do believe that this specific population, the data remains inconclusive. The one study we have in the right group did demonstrate some benefit, but again, small numbers. And then obviously we cannot look at the Abdul Rahman study. I think there needs to be a strong, well-designed study on treating subclinical hypothyroidism in the infertility population with enough power to say that whether it is beneficial or not. And as I mentioned, the one that does target our primary population was not well powered, but did demonstrate positive benefit of being on treatment. And the other one in our primary population appeared to have falsified data. And all the good RCTs that are out there have actually been in euthyroid TPO positive patients, so not the population that we are talking about here. So I'm going to just go to this slide here. As of July 2024, Stanford REI reviewed all of the evidence and felt that we should continue to treat subclinical hypothyroidism in our infertility patients, but with a discussion of risks and benefits. I didn't get into any of the RPL data today because we didn't have time, but we also will consider we would treat an RPL patient who actually has subclinical hypothyroidism. So this is kind of where we were at when we designed our own algorithm. And I just wanted to show you guys, it's a little bit busy, but we will, as a group, plan to continue screening our patients who intend to conceive with infertility and RPL using TSH. And if we do find a TSH greater than 4.12, we'd repeat it with another TSH and free T4. If it's greater than 4.12 and low T4, or if TSH is greater than 10, we would treat. But if elevated again with a normal T4, given the limited evidence, we recommend treatment with LT4, but obviously have a discussion. If we decide to not start treatment, we would consider TPO antibody testing. And if that is positive, or if there are other high-risk factors like family history or whatnot, we would repeat a TSH and free T4 about every 3 to 6 months. I know that the endocrine department, I think, would agree with maybe the 3-month interval, and that might be what they say in their guidelines that come out, but that's sort of what our group is doing. And goal of treatment, if we do start treatment, is TSH less than 2.5. So basically, we as a division did not agree with the recommendations of ASRM, mainly because the data really is weak and it doesn't really focus on the population. And the one RCT that I felt like we could consider actually did demonstrate some positive benefit. So we felt like we should continue to do so. Thank you. I know this was really long, but I appreciate you guys for listening. Thank you to my entire REI family for their support over the past 3 years. and also to my family and friends. And any questions? I know we have 5 minutes, but hopefully we have enough time for some questions.
Terrific. Thank you, Esther. That was truly amazing and so comprehensive. A lot of the comments in the chat, exceptionally well researched, detailed, and well presented. Kudos. Amazing presentation, so thorough. Bravo, and so on. Anyway, so a few questions. I think we'll have time for a few. The definition of LGA and SGA, are they different in Chinese women? You know, this goes back to your OB studies, I assume.
I will admit that I did not look into the definitions, but that I could look into it later. But I'm sorry about that. I did not look into that.
All right, terrific. Thank you. And then what is the optimal interval to recheck thyroid function tests in the reproductive age females, assuming subclinical hypothyroidism?
So I think that so it depends, right? If you're in the middle of treatment and adjusting treatment dosing, then every month as is standard. And then I think 3 to 6 months is reasonable in a population of people who are trying to conceive. And then obviously with a positive pregnancy test, I would check another TSH because there can be higher. And so that was the other point where we kind of differed with endocrine is, you know, if we tested a TSH at the time they had a positive pregnancy test, we decided as a group to only treat if the TSH was greater than 2.5. Whereas I think our endocrine colleagues do automatically increase the dose when a patient says they have a positive pregnancy test, regardless of what the TSH actually is. So they'll go up on their dose by 25%, whereas we will check before we treat because we're just trying to limit, you know, the side effects of like thyrotoxicosis or whatnot in the subclinical population.
Terrific. The study seemed to imply that all other factors were normal. What happens when data don't separate out women with obesity, diabetes, and so forth?
So that's why I think the studies initially were kind of a catch-all, and then when they did their sensitivity analyses, they would pick out all of the populations that you mentioned, like diabetes or anything else that might impact TSH. So agree, I think it would be an interesting study to look at the infertility group and subclinical in large numbers and then do a sensitivity analysis looking at whether other complex diseases that can impact thyroid function will have an impact.
Great, thank you. Does the level of TPO antibody make a difference, like 80 versus 800?
So I think there isn't data that says, you know, higher antibody positive definitely makes a difference, but I do think that some of the criticism of the studies that looked at the TPO positive population felt that the borderline values of like higher than 60, around 60, 80 that you mentioned is not truly TPO antibody positive. And so I think that is a criticism of the studies.
Terrific. Okay. Lovely presentation. What do we know about the cycle-by-cycle relationship between TSH and, say, FSH, especially when very early in the cycle when an FSH pattern may be establishing itself?
So I believe the data on that is not there's not much on there. The basic science studies that have looked at TSH and folliculogenesis says there's some impact at the level of the granulosa cells, and so there's some impact there. And I know FSH has an impact on the granulosa cells too, so it's probably related, but I don't have the exact mechanism.
All right, terrific. Well, I think we're going to have to call it there. There are a couple of other questions, unfortunately, we're not going to be able to get to. So thank you so much again for an amazing presentation. Exceptionally well done. I hope you'll write it up and challenge ASRM. Again, happy Thanksgiving to everybody, and we'll see you after the holidays. Take care.